and welcome to Innovation Celebration, the show where we celebrate recent advancements in science and technology, the people and ideas that make them possible, and the ways in which they enhance human flourishing. I'm Angelica Walker-Werth.
And I'm Thomas Walker-Werth, and today we want to talk about mental health, and you've got some advancements in the sort of medical treatment of mental health. But before we get onto that, I've been looking more at the psychology and the philosophy of how we approach mental health conditions. Conditions is really not a great word to use, actually, because that's really the point I want to get at, which is that there's this, over the last 100 years or so, when there's actually been a science of psychology, the big question has been, are deviances from normal behavior an illness or just people being different? What nowadays it's popular to call neurodivergence, just being mentally different as opposed to having some kind of thing wrong with you. How do we define one from the other? And that overlaps somewhat with the fact that mental health and physical health are different things. That you can very easily tell what the function of your leg is supposed to be or the function of your heart is supposed to be, and when it's not doing it right, the consequences are obvious. With the mind, it's much more complicated, because how do you tell if a mind is functioning correctly or not? What is functioning correctly? We need an objective definition of that. We've really struggled to arrive at one. And as I say, it's a relatively recent science to begin with. Prior to the late 19th, early 20th centuries, it really wasn't taken seriously as a science at all. But nowadays we have the American Psychological Association. I think I said that right. Their definition is deviant, distressful and dysfunctional patterns of thought, feelings or behaviour is their definition of a mental illness. I don't think some of those words are terribly helpful, but the one that is, I think, helpful is dysfunctional. And that's often taken to mean behaviours that make it difficult for you to function in society. And I can talk more about this when we get into the history, but historically that's tended to take the form of society versus the individual. It's something Freud talked a lot about. And then the subsequent debate after that is either the individual has something wrong with them that means they can't work with society, or the counter-argument to that tends to be society has something wrong with it that's causing us to have these problems. And those tend to be the main two positions. I don't think either of those is correct. And I think we need to look at it more on a philosophic and individualist basis. And so my sort of, for what it's worth, attempt at a philosophic definition is a behaviour that prevents you from rationally identifying and pursuing your values, which is the thing that all of us need to do in order to thrive in life. So that's my sort of starter for 10 on the philosophy. You seem to have a couple of points you wanted to make during that.
Oh, yeah, sorry. I didn't mean to look like I wanted to interrupt you, but no, that's, I think, a very important point there is that, first of all, some societies facilitate human flourishing and some do not. So there is something to the idea that if you don't seem to be able to work in society, that might not be your fault. That might be society's fault, but you can't assume that either. I think you have to take it on a case-by-case basis.
I kind of want to push against what I think has become popular recently. It's almost nihilistic philosophy of saying that, the world is wrong. You hear this so much now, and then people throw it at capitalism quite a lot of the time, but you can throw it at the government as well. Like, this whole system we're in where we have to work this way and, we're wage slaves and all of that is the cause of all these problems. And obviously, legitimately sometimes an external factor like that is the cause of your problems in life, and sometimes it isn't.
Not capitalism, but...
Not capitalism usually, but obviously specific things, concrete things. Your job may well be...
Yeah, your job could be stressing you out,
sure.
But, it's perfectly reasonable.
But the solution to that is a combination of recognising that external factor and then changing your life accordingly.
Mm-hmm. So a better definition definitely has to do with, does it actually stop you from doing what you need to do to function well as a human being? So... Yeah. But no, I think that's a great introduction on the philosophy side. When we're talking about treating mental health, the other thing that I think we need to talk about, you touched a little bit on the difference between like physical health and mental health. I think we need to dig into that a little bit. Yeah. And it's become quite popular, as you say, I think, to equate mental health with problems in your brain, with hormone levels not being quite right. And there's a reason to do that. And the reason to do that is that we have observed, not me personally, but scientists have observed that when people are experiencing, say, severe depression or bipolar, or, any of these serious mental conditions, you can see that the levels of certain hormones in their brains aren't quite right. but that doesn't explain why those levels are the way that they are. So it's really only, if you're trying to treat the hormone problems, you're treating one level below the symptoms, which is still an improvement. We'll get to that when we talk about the history and the development, but it's not really getting at the root cause. And there's a lot of debate about what precisely the root cause is. And I submit that there may be, in a lot of cases, again, this probably needs to go on a case-by-case basis, whether that's a disease-by-disease basis or an individual versus by individual basis, as the case may be. But probably in some cases, genetics plays in some cases, your environment plays in, like we were talking about before. But I also wouldn't discount the effect of choices. Obviously there are things like if you take certain drugs, that's going to affect your mental state, but also, if you've ever gone for a run or exercised, that makes you feel good. And the reason that makes you feel good is because of the hormones in your brain, but you cause those hormones to be released by doing the exercise. Yeah. So I don't want to downplay the role of free will, and we'll come back to that.
Yeah, and you've kind of brought up 2 points that I wanted to speak about there. One is that the psychoanalytic trend that Sigmund Freud started was what people describe it as very pathological. It's very based on symptoms. So it's, you behave this way. Let's try and come up with a theory as to why you're behaving that way. And then Freud invented a lot of stuff, egoid, superego, all that kind of stuff, which wasn't based in evidence. It was, here's a conclusion. Let's try and come up with a complete a priori theory as to why that's the case. And then latterly, there's been this, somewhat more positive trend to try and move towards, okay, let's actually look at the evidence biologically, and you get this expression now, everything psychological is biological, which isn't necessarily true because we don't understand the consciousness aspect of psychology. We understand, like you say, there are physical issues with the brain sometimes, and then sometimes there are just psychological things that don't have a corollary there. And even if they do, that doesn't explain the complete context. You undermine the conscious free will aspect of psychology if you just go straight to the physical. And that's something that Thomas Sass, if I say his name right, was quite keen on. Like, he wrote a book called The Myth of Mental Illness, and that caused a lot of people to say, what you're saying, mental illness doesn't exist. And that wasn't his point. He was saying that there are some genuine issues you can have with your brain. You can sustain injuries or have defects in your brain that inhibit your ability to do certain things. But outside of that, we should be really careful about defining any behavior as a mental illness. We should, just acknowledge that there's a diversity of ways people behave and then let them come to their own without any coercion. Like, he was very much against sectioning and forcibly treating people, and let people work out their issues as much as they need to be able to function as much as they want to. Yeah. And let that be their decision.
Yeah, as long as they're not endangering other people, that seems like a reasonable way to go about it.
Yeah, and then just regular law can deal with when people are in danger.
Yeah. To touch on your point about consciousness there, that's what philosophers call the hard problem of consciousness, which is that from a philosophical and a biological perspective, we don't fully understand why we have the consciousness that we do. And different people define consciousness differently, but other beings that might potentially have consciousness, we don't know why they have the consciousness that they do. It doesn't seem to be fully explained by our brains, but there's a lot of really interesting things we won't go down.
Yeah, you don't need to get mystical about it.
No.
You don't need to say, there's Christians and other religious groups, even Scientologists, who object to psychology on the basis of their beliefs, and it's you don't need to make up anything else like a soul or whatever other system you might have. It's just that you have to accept that we don't understand where consciousness comes from, and you can't go on this completely physical basis of approaching these things when there's a whole dimension to it that we don't understand properly. Which
means, doesn't mean that we'll never know. But at the moment, nobody has really explained that very well. But I think we're ready to move on to sort of a history of these fields. I did want to just say, for our viewers' sake, that we have divided the labor such that you're going to talk more about therapy and psychoanalysis, and I'm going to talk more about medical and other physical interventions. Neither of us is trying to diss the other side. This is just how we divided the research. So
and we're also going in very much as we're not experts by any means. No. We've done our research and we bring our philosophic, that's the expertise we bring, is our philosophic understanding to these debates. But obviously we're not speaking as experts, as we are not in any of these things we talk about on this show.
No, I took one class on psychology. That doesn't make me an expert.
And I've done a lot of reading about it over the years, but again, we're approaching it from a philosophic standpoint.
Okay, do you mind if I...
Yeah, because I've already talked a little bit about Freud, and that's where I was going to start with my history, but
sweet.
I'll start into you.
I'll start, but feel free to jump in if there's like interesting parallels or contrasts that you want to make about this sort of timeline here. So prior to like the late 1940s, you didn't really see any sort of psychiatric drugs. That's what I'm going to call them. There are a number of names, antipsychotics, whatever. I'm going to call them psychiatric just for the purposes of the show. But you didn't really see any psychiatric drugs except for sedatives and hypnotics. And those were pretty much only used in asylums, and they were not intended to treat the illness. They weren't expecting to fix anything with these sedatives or hypnotics. It was just if somebody was having, a moment where they are kind of being crazy or whatever, then they would use a sedative. There was no expectation this was going to fix anything long term.
Yeah. I also had a bit about asylums, just talking about the conditions in them and the way they were operated. There were two really interesting exercises to make a point about this publicly. One was in 1922, where Nellie Bly, who was a pioneer of investigative journalism, she did 10 days in a madhouse, it's called, where she went inside and just basically reported afterwards, having sort of faked her way into one, on what the conditions were and tried to raise awareness of that. And then much later, in the 60s and 70s, you had the David Rosenhan experiments, which he then published as a book called Being Sane in Insane Places. And that was a wonderful one because he and 7 other people again faked their way into various asylums or institutions by that point. And the interesting find of that was that in order to get out again, even though as soon as they were in, they started behaving sanely and just saying, I'm fine, acting like a normal person, it took them 19 days to get out. They could only get out when they admitted to having a condition and agreed to go on a course of treatment for it. So his highlight there was that they saw these conditions as fixed. They had a sense that the person couldn't change of their own free will, that they were stuck with whatever condition they had, and they were only in remission if they were improving. It wasn't that they had recovered or overcome. And one little just interesting side of that is after he published his study, another institution challenged him and said, okay, send more fake people to us and we'll figure out who they are. So he said, okay then, and they did. They weeded out about a third of their patients, and he hadn't sent any. So that was wonderful. Interesting way of doing science, but it highlighted the point that it wasn't being done scientifically.
Sure. Yeah, and I think there's sort of a bias sometimes in these fields that when you're used to looking for something all day long, you see it more. It's like you and I, when we're out and about, we count dogs, and as a result, we see more dogs because we're looking for them. It's the same thing.
We should contextualize that. Like, we had one trip where we just saw a lot of dogs at once, and ever since then, we've not been able to resist ourselves counting dogs because it makes us notice all the cute dogs.
Exactly. Yeah. But because we're looking for them, we see more of them than we otherwise would, which is great because we love dogs. But it's the same thing. If you're looking for mental illness, you'll see more mental illness. If you see the same thing with police. Police are used to dealing with people who are criminals by their definition, and they're therefore more likely to see criminal behavior or criminal intent in people even when it's not there. So that's one aspect of it. And then, it just wasn't really being... I think there was a change that happened in the 20th century, just in attitudes toward mental illness. I read a lovely paper on psychiatric treatment in the 20th century, which I'll link in the comments. It was quite long, but quite thorough. It was talking about how not just the emergence of some psychiatric drugs, which I'll get to in a minute, but how the attitudes towards them changed as well. And I think mental illnesses were definitely not considered to be something that were treatable until the 20th century.
Yeah, and that's where I do want to give some credit to Sigmund Freud, because I kind of knocked him a bit earlier, but he did raise the recognition of psychology as a science, and he also popularized the idea of talking about and analyzing your emotions and your feelings. So he actually did a really useful bit of work there. He just came to some wrong conclusions because I think he had an upside down methodology in how he approached it, but he nevertheless did a really good job of popularizing the whole issue.
Yeah, I've heard it said that Freud asked a lot of important questions, even though a lot of his answers were wrong.
Yeah, and unfortunately, they're still everywhere in the culture. We still talk about ego and retentive, anal retentive and all this stuff, which is complete pseudoscience.
Right.
But it's, for some reason, we still treat it like it's legitimate theory. But yeah, he did useful work.
Yeah. But yeah, so prior to the late 1940s, we didn't really have any sort of psychiatric drugs outside of these sedatives and hypnotics. 1950 rolls around, and we suddenly have a treatment that's actually relatively successful in treating schizophrenia, and that was eventually modified to be able to treat depression, anxiety, and certain phobias. It was sort of interesting the way they found it, because they actually played with antihistamines, which are what you take for allergies, and they've gotten better now, but it used to be that if you took like Benadryl, you would fall asleep, almost certainly. And so researchers looked at antihistamines, probably long before Benadryl, and said, wait, that's a sedative, we're using sedatives, can we use that? And it turns out that they could, to actually treat schizophrenia. So these early treatments for schizophrenia and depression and so on had really serious side effects. Like, side effects were basically a given. One of the most common was apathy, that you didn't care. So you weren't freaking out anymore, but you didn't care about life anymore.
Yeah, it's not an improvement, really.
Tiny improvement, really, but it was still a breakthrough, because a lot of those people who had been consigned to asylums and there was no hope of them getting out, and they were being subjected to shock therapy and lobotomies and all of that, were able to leave the asylum and live just taking a pill every day, basically. Yeah. So it was an improvement, even though there was the serious drawback of these side effects.
Yeah. I think also one other thing that helped raise the profile of mental illness in the first half of the 20th century was the two world wars. Because you had so many people coming back with what we would now call PTSD.
But that wasn't a concept then, yeah.
No, they called it shell shock.
Right.
Because, it's just so, people hear a lot of explosions and see unpleasant things, and then they freak out. And, they were punished for that in the First World War, and then after the Second, really just thrown into a room, and we don't know what to do with them. Interestingly, PTSD is a good example of where understanding the physical as it relates to the psychological is important, because PTSD can cause higher rates, I've got it in my notes here, higher rates of digestive, respiratory, circulatory and infectious diseases because of the enteric nervous system, which is part of your autonomic nervous system. So it's what you call your second brain. It's that direct link between your conscious mind and your body's automatic nervous system, effectively. So things that are wrong in your head can affect your body as well, is the point. And that's a good example of where being aware of that connection is important. You can't just treat it detached from the medical, but you also can't treat it detached from the psychological. You have to integrate the two.
Got it. Yeah. So following up from that treatment for schizophrenia in 1950, throughout the 1950s, we had a whole slew of different psychiatric drugs being developed, and two things to note there. One is that the drugs that were developed in the 1950s and the 1960s still form the basis for the different classes of psychiatric drugs that we use today. And the other thing to note is that these were not usually being recommended or sold as a replacement for therapy. These were being sold as a complement to therapy, and a lot of therapists really appreciated it. It was marketed to therapists as, here's how you can be more effective with your patients. Have them take this in addition to seeing you, type of thing. And I think that's how it's often still used in the US. I mean, some people are just on medication, but I do know a couple of people personally who have really benefited both from taking medication for their depression, anxiety, whatever, and seeing a therapist. So
yeah.
And they wouldn't recommend one without the other. So marching right along then, in the 70s you sort of had a lull. There wasn't really too much development going on in the way of psychiatric drugs. In the 1980s, we had a really interesting situation. There was a whole resurgence because of the rediscovery of clozapine. So clozapine had been a drug that was discovered earlier, and I think it was the late 50s, wouldn't swear to that. But there were no major side effects to clozapine, and so people thought, well, all the other drugs that are effective have side effects. Clozapine doesn't, therefore it cannot be effective. Not quite right. So that sort of rediscovery, by the 80s, people are realizing like these side effects are actually a serious concern. Some of them have safety effects. So we really want to be finding drugs that don't have side effects. And clozapine was one of the best. Feel free to jump in at any point here, but
Well, really, I mean, I've kind of made my point. I have some other examples I want to bring up, but the main one that comes in now is that you're talking about the medical model period.
Yep.
And that's really seen as having been superseded. I don't know if you're going here by yourself, but been superseded by the biopsychological approach that's more in vogue now of trying to merge the two, like I was talking about earlier.
Yeah, we'll get to some stuff that kind of touches on that, but I wasn't aware of that term. So then following this rediscovery of clozapine and a resurgence in development of psychiatric drugs in the 1990s and the early 2000s, you had a lot of companies claiming that their drugs were this new group of psychiatric drugs and that they were safer and more effective than the earlier psychiatric drugs. Unfortunately, that was mostly not true, with the exception of clozapine, really. And then you also had a sort of major, I won't say marketing problem, but a major publicity problem with the publishing of a book called Listening to Prozac in 1994. Mm-hmm. Prozac, if you're not aware, is an antidepressant that used to be really commonly prescribed. The brand name for it. I'm not sure what the actual name for it is. But this book argued that Prozac and other drugs like it actually remade your personality or remade yourself, and that this had really concerning implications for philosophy and for how we think of ourselves and so on. Yeah. I would argue that that is really an intense form of determinism, because if you think that our personality and ourself is entirely made by the hormones in your brain, then of course a pill that messes with the hormones in your brain will change your personality. But a pill doesn't make your choices for you, and so I don't really think that does remake your personality.
Yeah, I understand the concern in a way.
Yeah.
I have the same resistance to therapy personally. Like, I think therapy is a great idea in theory, if it's done right, which it can and can't be, depending on who's doing it and what methodology they're using. But I've always been personally resistant to therapy, even though I know I have anxiety issues. Like, I've always been resistant to getting that dealt with because I don't want to be overdiagnosed, like misdiagnosed. I don't want somebody to say, oh, you have X disorder, X dysphoria, and that comes to define me. Because I've seen other people do that where... like you kind of let you say, well, okay, I have this condition, I that is what I am, I can't change, and I really want to just maintain the mindset of I have the power and the free will to choose how I handle things and work through things on my own accord. Now, I know there are some therapists who will work with me and help me do that, but I'm really reticent to go into that relationship without being confident that they have the right epistemological approach, right philosophic approach to dealing with the things I need to deal with, and I don't feel like I need to deal with them enough to, do that right now. But that's I understand that fear that the treatment outsources what should be your process of dealing with something.
Yeah, but in either case, it affects you, but it doesn't change you. Both the chemicals in your brain might make you feel a certain way, but they don't make your decisions for you, and they might make you more likely to do X, but they don't take away your choice to do X. And same thing with therapy. A therapist might affect the way that you think of things, hopefully for the better, if they're a good therapist. And they might, I think, probably the better therapists focus on teaching you strategies and ways to deal with things on your own. But they don't change your personality, and their diagnosis doesn't define you unless you let it.
Yeah, exactly. You still have that free will, and I've seen people fail to do that and let a diagnosis be their excuse for not improving their lives.
Right.
And personally, friends of mine I've seen do that. It's quite tragic when you see it. Equally, I've seen, there are people who know they have something who still push themselves to improve and change. So it does depend on the attitude you choose to adopt.
Yeah. There's a lot that's up to your choice, and how you think about things is one of the things that's most fundamentally up to your choice. Yeah.
Talking about misdiagnosis and overdiagnosis, sort of humorous example of the fact that, and I think this is something that Thomas Saz anticipated, but that's really proliferated recently, is the inventing of new disorders or illnesses to explain every behavior under the sun. My favorite one is internet gaming disorder. But just any behavior that's at all potentially seen as deviant or dysfunctional gets a name, even though there's really no evidence-based reasoning to say that it's that same pathological approach that Freud used. There's a consequence here let's make up a cause for it, instead of actually identifying an evidence-based reason to believe there's an identifiable condition.
Yeah, and you see that with social media too. There's a lot of self-diagnosis or people diagnosing themselves because of the content that's been shown to them. There's even one person who sort of wrote an article. I unfortunately didn't read it in preparation for this show. I just read it out of interest, and so I don't know where it is now, and I can't link it. But she was basically arguing that the TikTok algorithm had like classified her as ADHD and was showing her content that would be relatable for a person with ADHD. This is she had like a PhD. I don't remember what in though. So anyway, I'm not saying that, so I think social media and the proliferation of these things, on the one hand, it's good because it does get people the actual information. Like, there are legitimate sources of information on the internet, but you do need to be careful with where your sources of information are coming from and on how much you let things like social media affect how you look at yourself.
Yeah, like healthcare platforms probably more useful than
those
Facebook.
Are probably good, yeah. And actually, I was going to get there in a minute, but one of the most recent sort of not really definite developments that I want to talk about, but we have things like telehealth becoming more and more of a thing, and like chatbots and ways that you can get in touch with therapists online, which, really help remove certain barriers to treatments for a lot of people who might otherwise not have been able to be treated. There's also been some research since about 2009, at least in the US, on mental health apps, like for your phone.
Yeah.
The argument being that they're cheap and they're anonymous and you can collect a lot of data, but there's, to my knowledge so far, no evidence that they actually help with anything except for collecting data, which is important, for example, if you're being evaluated for something like bipolar, but, it's helpful to track your moods and things like that. But other than that, I'm not saying there's not potential, but I've not seen any.
Well, there's sort of two categories there, isn't there? There's apps that are specifically designed to track a condition, and then there's apps that are designed to help you improve in life in a particular area of focus. Like, so I think that second category might be more effective, where it's things like Headspace or whatever that like let you think, encourage you to take time to think about your thoughts, or help you keep lists and remember things, or help you focus.
Oh yeah, I'm not saying apps are useless for your mental health. Apps, yeah. And I know a lot of people are a big fan of certain meditation apps. Calm, I think, has been recommended to me a few times. So if you're a fan of using those, definitely wouldn't knock that, because I haven't tried it.
Yeah.
But yeah, so I mentioned earlier that getting back to I'm almost done with my history bit, promise. So following I said in the 1990s and the early 2000s, there were a bunch of claims of drug companies saying our drugs are better than they used to be, they're safer, they're more effective, but that wasn't really true. So then you had, especially from the 2005 to 2015 type era, a whole bunch of lawsuits as a result of that. And I think there was sort of declining trust as a result of that as well. And the paper that I read that walked through this whole history of psychiatric drugs concluded, quote, other than clozapine, all antipsychotic drugs, new and old, have nearly equivalent efficacy, all produce nasty side effects, some potentially fatal, and none works nearly as well as clinicians and patients wish it did. So it's a bit pessimistic. This was published in 2019, this paper, but it is important to keep in mind that no drug is a miracle, and although there's still research going on into finding better drugs and drugs that have fewer side effects, and I'm going to talk about a few of those in a minute, it's really, before you start on a drug, it's really worth considering that there probably are side effects, and you really need to take into account all of your options. Yeah,
I think generally if there's a kind of free will based, choice based solution, if you can work through a problem constructively with your own thinking, that's always a preferable option to my mind than chemical intervention.
Yeah, but there's always, there's a point to which things are out of your control, and you do need chemical intervention. So I don't want to, I don't want to act as though that's not the case for some people. But
although if you're able to make that choice, then in a sense you probably are able to work through the problem constructively.
I would point out that there are a lot of mental illnesses where you have moments of clarity and moments where you're not really all there. So if in your moment of clarity you're able to make that choice, but in other moments, Okay, well, that's all I had for history. So did you want to add anything before we move on to recent advancements?
Well, recent advances are going to be mostly you, because I'm dealing with the philosophic side of it, really, which is just the same questions that have been hanging around for 50 plus years. So I have a few other people I want to call out, but they're not recent. So it might be better if you work through the recent medical advances and then I swing back to talk about the philosophic history, because I just have one or two more points I want to make on that.
Sure, yeah, okay. So I divided these up by the conditions that they're meant to treat, although I actually have 4 for depression and then 1 for each of 3 other conditions.
Right.
So I'll rocket through these, but stop me if you want to ask questions or comment.
Yeah.
So first, in 2020, the study was published that ketamine is actually a fast-acting antidepressant. So there were two advantages to using ketamine to treat depression. One of them is that it acts in hours, not weeks. So most antidepressants on the market, you have to take for 2 or 3 weeks before you start to see any difference, which obviously is disheartening and not useful to people in that 2 or 3 weeks. Ketamine acts in a couple of hours. And then also just not all cases of depression are treatable by the antidepressants that we have on the market. Ketamine worked in some of those cases where what other drugs weren't working.
Yeah, obviously with ketamine, just it is a horse tranquilizer, so
don't
be very careful.
it. Stick to the dose you're
I'm not even
given.
sure about the legality in different countries, but
legality on all these will vary. I think this study was published in the U.S. and there's 1 or 2 on here where I'll mention that it's been FDA approved, but obviously consider what country you're in and what the laws are like there, because they do vary quite a bit. Next one goes back to what I was talking about at the very beginning with the fact that there are different causes for the chemical imbalances that can cause you to feel a certain way. And so there have been a number of studies, most recently a 40-year study that was published in Finland, linking the microbiome, which is the community of bacteria and other small organisms in your gut.
I love the word community, like they have a little village hall meeting.
Ecosystem, whatever. the group of small organisms, mostly bacteria, that live in your gut. And they've actually successfully linked a particular type of bacteria, as I say, over a 40-year study, so this is quite a significant time period, to depression. And so there are 2 benefits to having made this link. The first is that we can look for drugs to treat it directly. And the second is that some people are saying, well, if it's your microbiome that is causing the problem, we can affect what goes on in your microbiome by what you eat. And so some people are working to develop nutrition plans and work with patients directly to affect their mental health condition by adjusting their diet.
Yeah.
Which is an emerging field, but an interesting one.
Yeah, and your diet does have a big impact on your mental well-being as well. Like it's worth really separating mental illness from mental health in a sense, because even if you don't have anything essentially wrong with you, you can still be better or worse off depending on how you live and what you eat. And you've discovered yourself recently that vitamin D inadequacy in your diet was sort of affecting your wakefulness and ability to focus.
Yeah, it was affecting my concentration and my energy levels.
You were freewheeling through that, but it was
pushing myself
unnecessarily difficult
to be awake. But it wasn't necessarily difficult because I moved to England and developed a vitamin D deficiency. So watch your vitamin levels, people.
Who would have known in a country where the sunniest part of the country is less sunny than the least sunny part of the US?
Of my country, and a note on that, vitamin D deficiency also can cause mood swings. So if you live in a place that is not very sunny and you are very much tired or experiencing mood swings, do get tested for vitamin D deficiency. So the next thing is a brain implant. And so these are obviously very risky and very expensive. The one I'm going to talk about is expected to cost about $35,000 to $40,000 per treatment, at least to start out. These things do tend to get cheaper as they go on, but basically, this brain implant was designed to treat epilepsy, OCD, and Parkinson's, and it's been adapted to treat depression. So far, they've only tested it in one lady, but it worked successfully for her, and she was at the end of her rope, and that she'd tried everything else, therapy, drugs, everything you could think of to try to fix her depression, fixing her diet, and so on, and nothing was working, but this brain implant did. And it worked very interestingly. What they did with it is they actually mapped her personal brain circuitry and how circuitry, I know it's like it sounds like electronics doesn't, but it's basically how they were referring to how the different neurons fire and everything in your brain. So they mapped how her brain was working under certain circumstances and then adapted the brain implant to stimulate certain parts of her brain when other things happen. So like if this happens, then you stimulate this part and so on. And she said that it really did help her. Now, brain implants have been tried for depression before, with a success rate of about 50%, which is kind of terrible. And they think the difference in this one is that it was personalized to her, that they mapped out her brain circuitry and personalized it rather than just saying, well, this will work for most people.
Who would have known? Individuals have different problems that you need to treat individually.
And different brains.
Yeah.
Our brains are incredibly complicated. It should not really be that surprising that, if you're going to affect the brain that directly, you need to have a good understanding of the specific brain it's going into.
Yeah, I mean, this is something that some of the people I wanted to bring up, like Eric Fromm, pushed against, is this kind of one-size-fits-all approach to psychology as well as treatment. And you need to deal with each individual's problems on their individual terms.
Yeah.
Whilst also objectively understanding the concepts. That's something he was big on, is not seeing dysfunction in terms of social norms, but trying to objectively define what's going on in each individual circumstance, which is going to be different for a person's biology, for a person's context, for a person's feelings. You have to deal with each person's situation individually. So same as you do in medicine, but it's so much more complicated when you're dealing with the mind as opposed to just dealing with somebody's heart condition. There still might be a variation that's specific to them that you need to consider before you give them a treatment. Lots of people, you've had this, people can't take certain painkillers, people can't take certain treatments for one thing because it might set off another thing. Even with the COVID vaccines, we had that. If you've got a certain condition, you shouldn't take it. But with the mind, that's just infinitely more complex.
Yeah, well, and that even does apply to just physical medicine. We've talked about it a few times on this show before, that they're developing personalized vaccines for this or personalized treatments for cancer. Like, they're finding more and more that with the tough things, the things we've had a hard time treating, it's usually because we need to not usually, but some of the time because we need to specify it to the individual that they're trying to treat.
Yeah.
So that's an interesting way that's going. The last thing I have for depression is 2 different sets of researchers independently have found that if you tweak, and I'll give their names in a second, but if you tweak or mimic psychedelics, in one case it was LSD, in the other case the psychedelic wasn't named, and make them to be non-hallucinogenic, you can cure depression in mice. Hopefully also in humans. Hasn't gotten that far yet.
How do you identify a depressed mouse?
Apparently there are certain behaviors that almost always identify, that show that mice are depressed.
Right.
I mean, I guess it's like most mammals have similar body language. So there are in one of the papers it talked about it, and I'll give the links below, but in one of the papers it talked about the specific behaviors they were looking for and how much it decreased them.
This is a good example, though, of where you can go too physical, because obviously a mouse can't conceptualize.
That's true.
So a mouse can't identify why it's depressed.
The mouse can't say, I'm depressed because X, or I've been depressed for this long. Like, they only have what they've observed in the lab. So the next step for both of these groups is to test it on people and see if it works well. But the idea of using certain psychedelics, I think, puts some people off, but it really is an interesting area of research. But the big problem with things like LSD is that they do cause you to hallucinate, but now we have the ability to adjust that. But before we go any further, I wanted to name the specific groups. So one group is in China. The Sheg Wang is the team leader, and Wang is at the Shanghai Institute of Biochemistry and Cell Biology, and they've found 2 versions of LSD, non-hallucinogenic LSD, that works there. And the other is a team led by David Olson. I think he's in California. And he has co-founded a company called Delix Therapeutics, which will hopefully commercialize these findings if, in fact, it does work for people.
And this is a good example of why banning drug research is an incredibly dumb thing to do. It's important that the law gets out of the way of that kind of research where it has the potential to really help people. We make that point all the time on this show, but it warrants making every time it comes up.
Until drugs are fully legal, we will continue to make it.
Well, just everything, like stem cell research, and it's all sorts of things where even nuclear research, like where attempts to regulate based on people's fears prevent people being helped in the long run.
Right.
And the show, as I try and bring the show back to its core function, we are all about flourishing. We're about the ways that people can live better lives. Mm-hmm. And so everything we're talking about is because we want to see people living fuller,
happier, lives. Yeah, absolutely. So then another recent breakthrough with treating mental health disorders is we were talking about PTSD earlier, and there were some clinical trials that finished, I'm not sure where they were in, sorry, that finished in August of 2021, and they found that therapy and MDMA is the formal name for the street drug known as ecstasy. But if you combine the two, the therapy and the ecstasy, you had really significant results in treating the PTSD, and you had no significant side effects. They were comparable to the control group. So, again, another case where we have a sort of street drug or something that you wouldn't usually think of for treating mental illness actually being quite successful.
Is that your...
That was PTSD. I've got two more if you're happy for me to go on.
Yeah, keep going, because I want to just go back to a psychology philosophy point, and then I'm good.
Cool. So for bipolar, for anybody who's not aware of bipolar, you swing between really euphoric, over-the-top delusions of grandeur states to seriously depressed states. They call it manic depressive. I don't know why.
I have a friend with it, so
there's nothing manic about being depressed.
Yeah.
But the problem they were having was that a lot of the drugs were good at helping, moderate the highs, but not so good at treating the depression part. But a study that concluded at the end of 2021 in the northeastern U.S. has found that a drug called lumateperone has been quite effective for the depression side without any serious side effects, and that's actually been FDA approved now. So it can hopefully go out there and start helping people with bipolar, at least in the U.S.
And what was the other one you wanted to bring up?
The last thing is a completely different category of physical treatment than the one I've been talking about. But for treating anxiety, a couple of doctors, David Rabin and Greg Siegel, I think it's Siegel, have developed a little wearable watch type thing. I don't think it necessarily has to be worn on your wrist, but it's called an Apollo wearable. And the idea is that it uses inaudible vibrations to stimulate your nervous system. Number one, to reduce stress. To reduce stress and help relieve the anxiety, but it has an accompanying app that can help you put you in the right state of mind for working, socializing, sleeping, meditating, whatever it is that you're trying to do. And you can actually purchase this online now, these wearables, for $350. And they have over 1,000 reviews on their website with a 4.6 star average. Some people said, I read a few of the reviews, most of them are quite good. Some people said it takes a couple of weeks to work. There were a few that said it didn't work for them. But
yeah, I do wonder sometimes when I was looking at things on this, I found some companies selling patches and things like that, which, when you read into it, seem a bit bogus. But there is a bit of the placebo effect in action sometimes with these things, and it's almost like, and it's kind of sad in a way, that some people need this feeling that somebody else or something from outside is interfering to start to feel better, even regardless of whether it is or not. And so that's why I think having that philosophy of what's the word I'm looking for, like that you do have the ability, the philosophy of agency, that you do have the ability to act and change things, would go a long way, because I think in our culture we tend to downplay our own agency nowadays. And the more people accept the idea that they do have the ability, I mean, again, not everyone does, like you can have conditions where you literally don't, but the vast majority of people do have the ability to take control and change things of their own accord. And sometimes they're doing that because they think something else or somebody else is doing it for them.
Yeah, but I wouldn't downplay that. I think in most people's cases, there are some things that are out of your control and some things that aren't. And it's always how I think about free will generally, is that there are some things that you can choose. You can always choose whether or not you think about something, right? But there are some things that you can't choose. And so I think the bottom line when it comes to mental health and what you can and can't choose is fix what you can. And if you're finding that there's something that you are repeatedly coming up against a stumbling block, that's where you might consider seeking professional help who might be able to evaluate or help you evaluate, help you work through things, whether you need some sort of medical intervention or not. But
but then I think the Thomas Sass point is that what we don't want then is, as soon as you do that, you're at risk of somebody saying, oh, you've got this, you must do this, and coercing you into their idea of how to fix it.
Well, they can't coerce you.
Well, they can to some extent. You can still be, sort of sent away and in certain situations. It depends if you're a threat to others or not.
I was gonna say,
it was more the case in his time than now.
Yeah, these days, if you are an adult, at least in the US, if you're an adult, you can't be sent to like a mental institution without your consent unless you are a danger to others.
Yeah.
So.
There's a whole question of consent there as well, but that's
which is an important, important but not super relevant.
Cool. Well, if you're all sort of done there's one other big clarification I wanted to make, which is just that a couple of the names I've mentioned, Thomas Saz and Eric Fromm, are often labelled anti-psychologists.
Oh.
And but that's a kind of mislabel that both of them rejected. Because anti-psychology was a movement. It was actually anti-psychiatrist. Sorry, not anti-psychologist. Anti-psychiatrist. But that's a label that was invented by David Cooper, who was a Marxist, who wanted to come to a de-individualized version of replacement for psychiatry. So instead of dealing with each person's problem, you see it from a societal level, and it's about each person's ability to function in the group and the group's health as a whole, which is obviously completely philosophically upside down because the group doesn't have health. Each individual person
have
has health.
Yeah, that does sound like a pretty Marxist mistake, doesn't it?
So people like Thomas Sass were very quick to say that's no, not us. And also, as I mentioned briefly before, the movement that David Cooper started, the Scientologists got on board with because they have their own nonsensical alternative to psychology, deontology, I think it's called, something like that. Not deontology.
Deontology is an ethical theory.
It begins with D. It's gone out of my head for a moment, but it's all about their concept of the soul and getting in touch with the long history that the soul has in Scientological belief. And
interesting.
Yeah, if dialysis, not dialysis is what you do to your kidneys, but it's a word like that. It starts with D. But anyway, so they all protest together against psychiatry because they all have, false philosophies that they wanted to put forward instead. Whereas the guys I'm talking about were not against psychiatry per se, but they were in favour of the individual making the individual's own choices and not diagnosing in the absence of evidence.
And taking it on an individual case-by-case basis, which increasingly seems to be more like the way to go.
But as is the case in every field, I increasingly realise, you have this binary of you're either pro this or anti this. You can't have nuance.
We can't handle nuance, people.
So I wanted to be clear that I'm certainly not advocating anti-psychiatry. But I am very concerned and very resistant to the sort of very diagnosis-heavy approach that's been taken really since the 60s, but increasingly now.
Yeah.
And the numbers of children that are diagnosed with ADHD now is absurd. Like, it's almost to a point where, okay, maybe that's just humans. Like, maybe that's actually just how a large chunk of the population is in their behaviours, and
the
just
thing is,
help them achieve their values and goals and identify them in knowledge of that, but don't treat it as an illness.
You can also tell, usually. Like, you can always tell. So, like, let me clarify. I worked with children, and I taught the same group of children for 3 years, and you could tell which one was ADHD. Or at least had the behaviors we associate with ADHD. I don't know what was going on when she was at home. I only saw her an hour or two a week. So there was something causing her behavior in a way that was not useful to her or the group. And it became more evident as she got older. And that's where some psychologists will say with ADHD is it's better not to diagnose too young, because a lot of the behaviors that are associated with ADHD are very common in very young children. Yeah. And as they get older, and this was certainly the case, I would never have said, oh, she's ADHD at the beginning, but as her group matured, her age group matured, the others were able to focus more easily and calm down more easily than she was, and that was clearly to her detriment. She was starting to struggle in school and things like that. So, again, that highlights the point that when we're talking about whether somebody has a problem, you do need to consider whether it's actually causing a problem for them. Yeah. And also just highlights that very young children probably shouldn't be diagnosed most of the time.
Yeah, it's like
there are exceptions, I'm sure.
It's like the discussion with autism, isn't it? Like, you have on the one hand, like, seeing autism as a learning difficulty that prevents you from functioning in society, and intense autism, and on the other hand calling it a superpower and saying it's kind of both and neither. Like, it's a way some people are that makes them better at some things and worse at others, and you need to work with each individual's unique circumstances to help them flourish in life.
Yeah, for sure.
But,
Well,
I think we've made our...
I was going to say, I think that's a nice note to end on, actually, really.
Yeah.
So thank you all for joining us for our mental health episode of Innovation Celebration. Please feel free to leave comments with suggestions. If you have things you might like for us to cover on the show, you can feel free to email us at angel, A-N-G-E-L, not L-E, I'm not an angle, at objectivestandard.org, and feel free to... or Thomas at objectivestandard.org. Give us suggestions, give us feedback, and feel free to subscribe wherever you are listening to us now. Thank you so much. Have a great night.